Thank you very much. So, treatment of celiac disease. So just a little bit of background. So first of all, celiac disease has increased 4 to 5-fold over the last 50 years. So this is a study done by Joe Murray from the Mayo Clinic, in which he took serum that was 50 years old, this Warren Air Force Base cohort. It was mainly young white men going into the Korean War. Apparently when you go into the military in the US, you give blood all the time and you can buy that for research. So amongst this, these young white men, 0.2% had a positive TTG and EMA. Then if you take their current cohorts, which is 70-year-old white men born at the same time as these individuals, or 20-year-old white men in Minnesota, it's about 1%. So celiac disease has increased 4 to 5-fold over 50 years. And this study reproduces studies done in Europe. Now, why do we have celiac disease? And in fact, why don't more of us have it? And how many more of us could have it? So to have celiac disease, you've got to have genetic factors. You've got to have this HLA-DQ2 or DQ8. And 30 to 40% of us have those. You've got to be eating gluten. 99% of us eat gluten. So potentially 40% of us can have celiac disease that we understand as having these autoantibodies, antibodies to tissue transglutaminase and the endomysium. That's why we consider celiac disease an autoimmune condition, pathology and symptoms. But in fact, only 1% of us currently have celiac disease. It's about 2% in Finland. So environmental factors are important. And the significance of this environmental factors came out of this observation of this Swedish epidemic of celiac disease in the late 80s and early 90s. They noted that infants aged less than 2 had this big increase in celiac disease. And what had happened is, but it wasn't seen in older children. What had happened is they had thickened up the infant formula with gluten. So kids aged less than 4 months were getting gluten, and there wasn't much breastfeeding. So they told the women to breastfeed and took the gluten out of the formula, and it went back down there. So environmental factors are very important. And which ones have been demonstrated? Everyone thinks that breastfeeding protects against everything, but it has not been shown for celiac disease. However, timing of gluten introduction has. Giving gluten before 4 months or after 7 months for the first time increases the risk. So there appears to be a window of giving gluten between 4 to 6 months to prevent celiac disease. Being born by cesarean section increases the risk, specifically elective cesarean section, not emergency cesarean section. Getting GI infections, it's been shown with rotavirus infections in children, and in the troops coming back from Afghanistan and Iraq, Campylobacter infections increase the risk. Children being born in the summer have increased risk compared to those being born in winter, and that's not clear whether it's the vitamin D status of the mother or child, or the fact that they're being weaned in the winter when they're getting their first gluten and getting their first GI infection. Antibiotic use has been shown, as well as PPI use. And more recently, a large study out of Norway showed that women who take iron supplements during pregnancy, their offspring have an increased risk of celiac disease. But we don't know why celiac disease can occur in a 8-year-old, 28-year-old, or 70-year-old for the first time. PPI use has been shown to increase the risk at all ages. So one general trend in these is that it might be the microbiome, of course. So current therapy is a gluten-free diet, and the NIH Consensus Conference recommended that patients be followed by physicians that are interested in the disease and to regularly see a specialist dietitian. When we found out how frequently people saw dietitians, as I pointed out before, 20% never saw a dietitian, 30% once, and 40% multiple times. And it's easier in different countries. I think it's tough in the United States. In Argentina, I went into an ice cream store, and it's okay for people who can walk in there and pick a different ice cream. I picked out menus in restaurants in Dublin, and you can see that they've got suitable for celiacs with an asterisk down the bottom. You note that two things here. One, they spelled celiac correctly, and two, none of the fancy desserts had an asterisk. So it can be difficult for patients. And there's not a high rate of adherence to the diet. The people seen in the celiac centers have a high rate of adherence. If you look at people in France, after a few years after diagnosis, the rate of adherence to the diet is about 50%. And there are multiple factors. Every food item, such as pasta or bread, costs 3 to 5 times more than the regular gluten-containing food. Poor availability, palatability. Most people with celiac disease don't get a signal when they eat gluten. Some do. Inadequate food and drug labeling, inadequate dietary counseling and follow-up. Participation in support groups is associated with increased adherence. Certain racial groups in the United Kingdom have lower rates of adherence. Dining out in restaurants can be a hazard, and I mentioned medications and communion wafers. There are social pressures. There's a high drop-off in adherence when children go from grade school to high school or high school to college. Transition to adolescence. A lot of children are being taken to the doctor by their parents, and then they stop going to the doctor. So there's inadequate medical follow-up. So the question comes up, do patients want an alternate therapy, a non-dietary therapy, a medication to help them with a gluten-free diet, or even replace the diet? And the answer appears to be a resounding yes. In this study from the United Kingdom, most patients, when asked, did they want a medication, said yes, and they were given choices, and vaccine was one of the choices. They preferred vaccines to the pills. We did a study in which we asked 339 patients, and as you can see here, more than 75% of individuals with celiac disease wanted a medication a great deal, quite a bit, or moderately, and only 11% said they didn't. Now, we hypothesized that it would be the younger, more recently diagnosed patients that would like a therapy. But in fact, it wasn't so. While most people wanted a therapy, men wanted it significantly more than women, and the older individuals more than the younger individuals. Other factors such as those eating out more, those that thought cost was an issue, and those that regarded their weight as being an issue, significantly wanted a medication more than those that didn't. And when we looked at a celiac-specific quality of life index, those that had a more inferior quality of life wanted a medication more. Those that had a lower dietary adherence test index or a symptom index, a higher symptom index, wanted a medication. So patients seem to want to have a medication. Most of them are kind of inspired by this and actually want a drug to replace the diet. And whoever you talk about around the world, like the Italians want a pizza, the Norwegians want their rye bread, the Americans want their bread. So there is an interest. But there's a lot of difficulties in developing a therapy. it's been very interesting for me to be involved with several of these countries. It costs about $1 billion to put a drug on the market. And there are all these different phases. Because such a lot is known about why individuals have celiac disease, probably more than any other autoimmune condition, there have been very rapid advances in the development of therapies. None of us digest gluten properly. We didn't evolve to eat wheat. We evolved to eat meat and then run away from where we got the meat. Because when we eat meat, our enzymes chop up the protein into single amino acids, dimers, and trimers. But when we eat wheat, we're left with these large molecules depicted here that are 33 amino acids long. And they get into the lamina propria either between the cells or through the cells by active transport. And when in the lamina propria, if this ubiquitous enzyme, tissue transglutaminase, is activated, as with a rotavirus infection, this large molecule gets deamidated, changing the size and shape of it, that just happens to allow it to fit into the groove of the HLA-DQ2 or DQ8 molecule sitting on T cells. And that sets off a cytokine response that will result in villus atrophy. Now, in addition, there appears to be an innate immune mechanism that causes damage to the epithelial cells. So you've got this adaptive TTG, HLA-DQ2 mechanism, as well as an innate immune mechanism responsible for celiac disease. And so you can get drug therapy designed at all these different stages. And there are several in clinical studies. One can take those genes out of wheat, right? Take those few genes out of wheat, but genetically modified food is not a very sexy thing these days. And people are worried that it might convert safe grains into harmful grains. Enzymes have been developed that digest this non-digestible gluten molecule. And polymers have been developed that bind gluten, similar to what we've been using, such as cholestyramine binding gliadin. So the use of enzymes is a common thing. We're used to doing that for patients with pancreatic insufficiency and those with lactose intolerance. And we're used to using polymers, such as cholestyramine. Drugs have been developed to block the gliadin getting through the tight junctions, lorazepatide. And then there's potential for therapies so we can act in the lumen, with the enzymes, this lorazepatide to block the gluten getting in. And then it's a little bit difficult to have these concepts of altering the immune system, but they did a study in Australia that I was very proud of, in which they gave hookworm to patients with celiac disease. And while the patients felt better, no difference could be determined. Another Australian group is developing a vaccine. Now, this is very interesting because if a vaccine works, the patients are going to have to keep eating gluten, and that might make them happy. But it's not clear who's going to get the vaccine and if it's going to work after you actually have the disease developed. But studies with celiac disease patients are difficult. Initially, they're gluten challenge studies in which you give gluten plus drug or placebo. So patients have to have symptoms when eating the gluten to demonstrate a benefit. The amount of gluten is difficult to determine, and it's somewhat difficult to find patients in remission. Going to the celiac centers gets a lot of patients, but they're not quite like the patients that don't go to the celiac centers. And it takes time for antibodies to develop. and biopsy is the gold standard. So these are somewhat difficult studies, and it's difficult to determine what the endpoints are. We had a development of therapies conference at Columbia University a couple of years ago, in which we had the FDA people, the companies, the clinicians, etc. We're going to have another one next year. But it was very interesting because the FDA in the States is not used to dealing with celiac disease. They're used to dealing with IBS, in which there's no pathology, and they're used to dealing with Crohn's disease and ulcerative colitis, in which pathology predominates. In patients with celiac disease, you have both symptoms and you have pathology. There are very few biomarkers available for celiac disease to replace a biopsy. The antibodies are not sensitive to getting small amounts of gluten. The biomarkers might not correlate with quality of life. And all drugs now require the patients to feel better. Like it's hard to get a cholesterol therapy medicine on the market now because it doesn't make patients feel better. A drug was failed in its primary endpoint to treat eosinophilic esophagitis because while it eliminated the EOs, the patients didn't feel better. So right now, patient-reported outcomes has got to be a primary endpoint of all the symptoms of all these studies. And it's very difficult when you're developing a drug for celiac disease because the gold standard is a gluten-free diet. And while patients might not like it, being on the diet, it's a very safe therapy. Therapies will be developed. Will they be able to be used in childhood? We don't know. There are lots of different questions, and celiac disease is a unique disease to study for these potential therapies. Now, what about prevention of celiac disease? So we know these bunch of environmental factors, so they can certainly be altered. 30% of children are born by cesarean section now. We've got to go back. We've got to attempt to reduce this high rate. We've got to encourage breastfeeding. Even the food allergy people are now talking about giving some of the hyperallergenic foods and gluten to children prior to the 6-month time period that is now recommended for the introduction of solids. So for children born to families that have celiac disease in it, they don't want to have more children with celiac disease if possible. So they ask us, what can they do? So what we do is give them this cheek swab for them to assess if the child has HLA-DQ2 or DQ8. And if that's negative, they can just go on their way and feed the child however they like. But if it's positive, we would then encourage breastfeeding for up to 6 months with introduction of gluten between 4 to 6 months, because that's what's thought to be most preventive. Certainly rotavirus vaccination is sensible to reduce viral gastroenteritis, and it's heartening now to see pediatricians giving fewer antibiotics to children. It is somewhat dismaying now that children don't develop colic, they develop reflux. And now many children are taking these PPIs that we know can alter the microbiome. Apparently, when you eat a bagel is a bagel, heavy and dense because it's got enriched gluten in it. There's a big influx of gluten into North America, and that's being added to many foods, and the bread industry is actually getting worried about that now because of this tendency for people to avoid gluten. And then there is the potential to avoid wheat, especially when you can have these inhibitory RNAs. And within Europe now, there's a large multi-center study call this Prevent CD, in which children are being randomized to different feeding schedules and timing of gluten introduction. And there will be other factors that are noted, like breastfeeding. Breast milk usually contains a little bit of gliadin and gliadin antibodies in it. And so we don't know what factor the mother having celiac disease and being on a gluten-free diet has as a risk factor for her offspring. So all of these are being studied in this very interesting and high expectation, multi-center, multi-country Prevent CD study in Europe. But like, we don't know what's going on. A lot of people are avoiding gluten, and this looks like California, doesn't it? I have an idea. I have no idea what gluten is either, but I'm avoiding it just to be safe. There's a lot of that going on, and it's somewhat difficult. Children can't go into a gingerbread house now without finding out if the home is produced in a facility that also handles wheat, milk, nuts, eggs, or soy. So times have certainly changed, and while we've got to ask patients about their family history of malignancy, we'll also be asking them about what they eat and how much of it they eat. So thanks very much.